My advice: don't go to the ITE test or the APIM without really studying nephrology. It's a topic that they like to challenge you on the board on the test. So prepare yourself for the nephrotic syndrome, renal tubular acidosis. Really, in nephritic and nephrotic syndrome, there is an easy way you can navigate. So make that as a habit, go for it as a routine. Check your patient. If you think he has proteinuria more than 3.5 grams, this is more likely nephrotic syndrome. You don't have to find all the characteristics of nephrotic syndrome: hyperlipidemia, edema, coagulopathy, this and that. There is few keys there you need to check. One of them is this is a systemic disease or it's just a kidney disease. If it's a systemic disease and the patient is diabetic with already established retinopathy or neuropathy, then this is very likely diabetic nephropathy. If the patient has other organs involved like a heart failure, ecchymosis, easy bruisability, and suspicious for amyloidosis, this is very likely secondary to amyloidosis, especially if you do an ultrasound or they told you about the ultrasound there's a large kidneys. The limited or the renal nephrotic syndrome, a young man with kidney biopsy that only showing fused body site or everything looks normal except the patient has the nephrotic syndrome, young age, then you think about minimal change. If the patient already has also elevated creatinine and high blood pressure, then you may think about FSGS, especially African American ones, and then maybe need to do, and this you can google it, just put nephrotic syndrome, you may find one of those ones from med study, and you can navigate. You can go if it's nephrotic syndrome with hematuria and RPCs cast, then you're going to check your complement. Again, you're going to ask, is this a primary kidney disease or systemic disease? Is this an Alport disease with hearing deafness, or is this hematuria that comes every upper respiratory tract? Then you think about IgA nephropathy. So always there is a key, but again, remember this is not step 2 or step 3. There is something hidden there. They may not tell you, but it's there. For example, you may ask about renal tubular acidosis, but they're not going to tell you, oh, this patient is anion gap is normal, but he has a metabolic acidosis. No, you'll have a patient who's fatigue, weak, there is the chemistry there is the anion gap is normal, mild acidosis. The patient is either they're going to give you the potassium is already high, or the patient just took an ACE inhibitor or aldosterone, or they may not tell you that, but they show you an AKG that he comes with hyperkalemia. And the AKG will not be difficult, but there is a peak T wave typical for hyperkalemia. Then you need to think about renal tubular acidosis type 4. They may not tell you the whole story and maybe give you a patient with an autoimmune disease, skin lesions, scleroderma. You think this is very likely typical for scleroderma, and the question will be about RTA type 1. They may give you a urine analysis, a sample with proteinuria, calcium, magnesium, phosphate there is in the urine. Then the question will be about renal tubular acidosis type 2. So the question will be there, but it's not super easy, but there is a trick, small keys you need to find. Hypomagnesemia, we know alcohol can cause hypomagnesemia, liver disease can cause hypomagnesemia, diuretics like thiazide can cause hypomagnesemia. They may have those answered in the question and tell you what is causing hypomagnesemia. All of them does, but which one is on higher risk? It's the thiazide. So you have to pick and choose thiazide over liver disease or alcohol disease. So study and read all electrolytes, hypophosphatemia, hypocalcemia will be there on the board. All acid-base imbalance with you need to know how to calculate the anion gap, the urine gap, the osmolarity, the delta delta. Do all of that for all metabolic acid base imbalance problem, so you can answer the question correctly. Alcoholic patient with alcoholic intoxication, they may have a question about alcoholic ketoacidosis, giving the IV fluid, dextrose, giving the thiamine, and maybe the question about what type of acidosis, high anion gap, NAGMA. There, the question may tell you he was overdose, intoxicated. They intubated him, then they used for Ativan for or one of benzos for withdrawal, but the patients came for also with a DKA. We corrected the DKA, the anion gap closed, but the patient continued to have acidosis, or after a short term of improvement, his acidosis worsened. Then they need you to pick that this is medication induced because of the Ativan, because the delusional constituent is there is an acidic. So that's why he continued to have metabolic acidosis. Hypertension, yes, there is many questions about hypertension, especially resistant hypertension, when to use more medications, and the standard or the golden idea about treating hypertension in addition to lifestyle and exercise. Usually when it's resistant, it's not just one medication. Don't keep increasing the dose. It's better to use two or three blood pressure medication than using a one or two medication with a high dose. Higher dose give you more side effect but less drop on the blood pressure. The other question, you may have a young lady with a resistant hypertension, but there is an image of an angiograph there that shows renal artery stenosis. If it's step two, they will ask you only about the diagnosis, but here they may try to challenge you and ask you what is the next step, treating him with add more antihypertensive medication or go for angioplasty or surgery. So the question is trying to tell here, do you understand that this patient need to be treated with blood pressure medication? It's the only time that you go for renovascularization. Usually the benefit with renovascular is very low in those patients, especially if it's been established hypertension, it's been there for long term, if it's and if it's bilateral, even unilateral with a single kidney. So when to go for renovascular, if it's been for short term, this is just a new discovered hypertension, it was already refractory and you tried the blood pressure medication and tried two and three blood pressure medications and it's not, including the ACE or ARBs, um, continue to have severe high blood pressure, recurrent admission with flash pulmonary edema, an AKI, and a contraindication to use of ACE and ARBs, then yes, you can try and go for renovascular, but avoid doing it also if the patient already has an established CKD or a proteinuria more than a gram, because those patients likely less and will not benefit from renovascular. It's already established and caused the damage to the kidneys, and they're not gonna ask you which is better, the surgical versus the angioplasty, because there is no major difference. Again, nephritic and nephrotic syndrome, small hands, small keys there, black, African American, high creatinine, obese, FSGS, diabetic retinopathy, that's diabetic nephropathy, no more investigation, no biopsy, hepatitis C, skin lesion, high creatinine, low C4, cryoglobulinemia, and understand and know cryoglobulinemia will be there on the test. Maybe you'll see a photo with purpuric rash. You may, the patient has a Raynaud phenomena, an ulcer, necrosis, livedo reticularis, peripheral neuropathy, arthritis, low C4, glomerulonephritis, rheumatoid factor will be positive in most of the cases. So understand this one will be at least one question there. Granulomatous polyangiitis, pulmonary syndrome, upper respiratory, hemoptysis. Patient will be positive for ANCA positive. They may not tell you it's an ANCA positive, but maybe they name it and give you the other name, which is proteinase 3 antibodies there, positive or not, or you need to request that test. Treatment will be about cyclophosphamide and steroid. Asymptomatic, painless hematuria, no family history, everything else is negative, then you need to think about thin basement membrane disease. If there is a positive family history, you think about especially deafness, you think about Alport syndrome. They have a question about low GFR, below 15, and what's next. You prepare them for dialysis and do the AV fistula. Kidney stones, the question again, it may be not that direct about the patient has already a calcium oxalate stone, but the patient may have chronic bowel problem, colon disease, intestinal problem, cystic fibrosis, bariatric surgery, Crohn's, and they keep coming with recurrent calcium oxalate stone, then your answer will be to give him citrate, as those patient already has low citrate, and that's increased the risk for calcium reabsorption and deposition and excretion in the kidney. And that's conclude most of the questions or most common questions on nephrology. Get ready, prepare, and good luck.